Hey everyone, and welcome to this explainer. Today, we're diving into one of the absolute most high-stakes, dramatic scenarios you can encounter in trauma medicine. We are talking about what happens when the body's ultimate structural shield, the pelvic ring, completely shatters. Made up of your hip bones, the sacrum, and the coccyx, your pelvis is incredibly tough. It's built to support our weight and protect some really vital, delicate internal organs. But what happens when a catastrophic force breaks that protective ring? What happens when the shield actually turns into a weapon against the vital urinary system tucked right inside it? Think of it kind of like this. What happens to the plumbing in your house when the actual concrete foundation cracks and shifts? It's a pretty gripping analogy, mostly because it's anatomically spot on. Your urinary bladder and urethra sit perfectly nestled inside this bony cavity. During high-energy trauma, when the pelvic ring fractures and displaces, the ligaments and bones that usually keep the urinary system safe can violently pull, tear, or even puncture that delicate plumbing. And the stakes here, for both the patient's immediate survival and their long-term quality of life, they seriously could not be higher. All right, let's just quickly run through our agenda. We'll be covering the basics of pelvic trauma, the pathophysiology of the injury, clinical signs and mimics, how we investigate the damage, managing the trauma, and finally, outcomes and safety. Section 1, Basics of Pelvic Trauma, Anatomy and Etiology. So the pelvis forms this remarkably strong ring. Tucked away safely right behind the pubic symphysis is the urinary bladder, and just below that, the urethra passes right through the pelvic floor. It's a fantastic, highly secure setup until a massive external force is introduced. When a force is strong enough to break that ring, the statistics are actually pretty alarming. In severe pelvic fractures, bladder rupture happens in up to 15% of cases, and urethral injuries, they follow pretty closely behind, happening in about 4 to 10% of cases. This is overwhelmingly seen in young adult males, simply because of their longer urethral anatomy. So we aren't just looking at freak, isolated incidents. These are highly correlated injuries. What actually causes this kind of damage? Well, we are almost exclusively talking about major high-energy trauma. Road traffic accidents, nasty falls from significant heights, severe industrial crush injuries. These are the kinds of mechanics that generate enough force to snap that pelvic ring. But here is a totally fascinating and absolutely crucial risk factor: having a full bladder at the exact moment of impact. Seriously. A distended bladder rises up out of the pelvis and becomes so much more susceptible to bursting during blunt trauma. It essentially acts just like a water balloon under a high pressure. Section 2, the pathophysiology of injury, tearing the plumbing. Okay, so how does the trauma physically wreck the urinary tract? When the pelvic bones fracture and violently shift around, the fixed points that attach the bladder neck and prostate to the pelvis get forcefully yanked. This leads to two very distinct types of bladder ruptures, and knowing the difference here dictates absolutely everything about how we treat the patient. First, we have extraperitoneal rupture. This is the most common one. It happens when sharp, broken little fragments of pelvic bone directly perforate the bladder wall, which leaks urine into the surrounding pelvic tissues. Contrast that with an intraperitoneal rupture. This is when a full, tight bladder bursts right at its dome, which is its weakest, most mobile part, and literally spills urine directly into the peritoneal cavity, right where all your abdominal organs live. Yikes. Now, when we look at urethral injuries, we divide those into posterior and anterior. When it comes to pelvic fractures, we are hyper-focused on posterior urethral injuries. The membranous part of the male urethra is locked tightly within the urogenital diaphragm. It doesn't move. So when the pubic bones suddenly violently shift, that fixed membranous urethra, it simply tears right away from the prostate. Anterior injuries, just for context, are usually from a direct blow right to the perineum, not from the shifting pelvic bones themselves. Section 3. Clinical signs and mimics. Identifying the danger. Imagine you're in the ER and a patient has just been rolled through the doors in absolute immense pain. In all the chaos of a major trauma scenario, what are the telltale signs we are actively hunting for? Well, a patient with a ruptured bladder will likely have a ton of lower abdominal tenderness and a complete inability to pee. If they somehow do, you're going to see gross hematuria, which is just visible blood in the urine. But the massive, sirens blaring warning sign for a torn urethra is seeing blood right at the urethral meatus. If you see that, along with some perineal bruising, maybe scrotal swelling, or a high-riding prostate on a physical exam, which means the prostate has literally been severed and shifted upward, you know exactly what kind of nightmare you are dealing with. But of course, trauma can be incredibly tricky, so you have to mentally run through your differential diagnoses. Is this urinary injury actually tied to the pelvic fracture, or is it just an isolated bladder trauma? Could it be a straddle injury to the anterior urethra? What if it's renal trauma way higher up in the kidneys, or even just acute urinary retention from a totally different cause? Going through a rigorous, systematic trauma assessment is exactly how medical professionals confidently rule these mimics out. Section 4. Investigating the damage, visualizing the trauma. Once the patient is actually stabilized, we have to visualize the trauma safely to confirm our suspicions. You just cannot rely on physical exams alone when someone's internal plumbing might be actively leaking. Step 1 of the sequence is almost always a pelvic X-ray or a CT scan. We've got to map out that broken bony ring and spot any major organ damage. But step 2 is an absolute must. If you suspect a urethral injury, you must perform a retrograde urethrography. This involves very gently injecting a contrast dye right into the urethra so you can literally see the tear light up on an X-ray. Finally, step 3, cystography, fills the bladder with contrast to evaluate for those extra or intraperitoneal bladder leaks we just discussed. Section 5, managing the trauma, the OR, and beyond. All right, the diagnosis is confirmed. The clock is ticking. The absolute priority is saving the patient's life, followed by saving their function. This takes a highly orchestrated, incredibly urgent clinical response. And surprisingly, the very first step actually has nothing to do with the urinary tract. It's the ABCs: airway, breathing, circulation. A shattered pelvis can cause catastrophic, truly life-threatening hemorrhage. So controlling the bleeding and stabilizing that broken ring with a pelvic binder or external fixator is the immediate life-saving priority. You absolutely must secure the perimeter before you try fixing the plumbing. Now, there is a crucial, non-negotiable rule here. If you see blood at the meatus and even suspect a urethral injury, standard urinary catheterization should be completely avoided until imaging is done. If that urethra is only partially torn, blindly pushing a catheter up through it can easily turn it into a complete, devastating tear. You never, ever want to make the trauma worse. Once the urethra is either cleared or bypassed by putting a tube directly into the abdomen, called a suprapubic catheter, we can finally manage the bladder. Connecting this back to our anatomy, if it's an extraperitoneal rupture where a bone shard just poked a hole in the bladder wall, it often heals perfectly fine conservatively. We literally just keep a catheter in place for a few weeks to keep the bladder drained. But if it's an intraperitoneal rupture where urine is actively dumping into the abdominal cavity, that patient is going straight to the operating room for immediate surgical repair. You have to fix that fast to prevent severe peritonitis and sepsis. Section 6. Outcomes and safety. Complications, prognosis, prevention. So the immediate life-or-death danger in the OR might have passed, but the aftermath of this casts a really long shadow. What actually happens next for this patient? Well, the complications can be severe and they drastically alter a patient's prognosis. In the early days, you're fighting massive hemorrhage, sepsis from urine leaks, and acute kidney injury. But the late complications are what truly change a patient's entire quality of life. As these super delicate structures heal with a lot of scar tissue, patients often face chronic urethral strictures that require repeated surgeries over the years. They can deal with urinary incontinence, and for many men, permanent erectile dysfunction, just because of the severe nerve damage from the displaced bones. Because the long-term prognosis can be so challenging to navigate, even with rapid and totally perfect surgical repair, prevention is paramount. We can fix the anatomy, sure, but avoiding that high-energy trauma in the first place is our absolute best defense. This means rigorous road safety measures, strict adherence to wearing seatbelts, and really taking workplace and fall prevention strategies seriously.